Hello. Perfect. I apologize for the delay. Yes, my email completely went down when I couldn't get into the Zoom. Um, awesome. So welcome to the May CMR Journal Club. Thank you all for coming. I know many of you are busy with preparations for the ISMRM, so we appreciate you being here. So for today, we have a couple of papers which are kind of highlighting one of the exciting things that we're able to do with quantitative CMR, namely making synthetic images. Typically when we think about making tissue property maps, we think that they could be very useful to help us identify changes to T1 or T2 or other tissue properties. One of the things that we can also do with these tissue property maps is to selectively generate contrasts that we think might be interesting for physicians. So to take the quantitative images and go back to qualitative images with enhanced contrast. So we have a couple of papers that are going to be talking about that today. So without further ado, I'm going to hand over to Dr. Jesse Hamilton and have him present his paper doing exactly that.
Great. Yeah. Thanks, Nicole and Matthias for inviting me. I just sent a request to share. All right, great. All right. So this paper is about using post-contrast cardiac MR fingerprinting. So using quantitative maps to generate LGE images that have multiple contrast weightings. So this was some work with Nicole and also with Imran Rashid and some collaborators. So he's a cardiologist at Case Western Reserve University. So just to get right into the introduction, as we all know, LGE imaging is extremely important. It's the reference for looking at myocardial scar and fibrosis. But one of the limitations of conventional LGE is that both scar and blood have very similar signal intensity. So, for example, if you have a subendocardial scar, it can be difficult to detect just because of that issue. Another issue is that LGE images tend to be kind of operator dependent. You need to run a TI scout, and if you don't select your TI properly, you can have incomplete nulling of the myocardium. And of course, there's dark blood techniques that we can use to kind of increase the contrast between blood and myocardium, but these require additional acquisitions. Um, so there's a lot of interest in doing, synthetic imaging, and all this means is that we, rather than collecting a dedicated LGE scan, we acquire quantitative post-contrast maps, and then use those maps in some type of signal model to simulate like virtual or synthetic LGE images. And some of the nice features are that this can enable shorter exams with reduced operator dependence because you can, after the acquisition, like adjust your TI and other scan parameters. So in this paper, we took our just kind of our existing cardiac MR fingerprinting technique and acquired post-contrast maps, and then used those maps to generate co-registered LGE images with different bright and dark blood contrasts. So getting into the methods, in this study, we scanned 15 patients at 1.5 T, and these were all people who had either a prior myocardial infarction or ischemic cardiomyopathy. And we acquired data using our just kind of our standard cardiac MRF sequence. So this is a single slice breath-held ECG triggered scan. So it's a 15 heartbeat breath hold. We reconstructed our maps using just a low rank subspace reconstruction with a kind of a preliminary cardiac motion correction step. So we registered all of the data to the kind of an end diastolic bin because our window is relatively long. It's a 250 millisecond scan window. And then we reconstructed maps using dictionary matching. So we did a block equation simulation that includes things like heart rate effects, slice profile corrections, and like inversion efficiency corrections. So getting into like how we actually generate the synthetic images, maybe I'll pull up this first figure. So we start with our quantitative maps, and what we do is we draw an ROI both in a region of normal myocardium and in the blood pool. And then we measure the mean T1 and T2 values for this specific patient. And then we feed those into a either steady state signal equations or a block equation simulation, depending on the type of image we want to generate. And then from this one acquisition, we can generate both a conventional bright blood PSIR image. This top panel is showing images with a T2 prepared PSIR simulation, so we can get different levels of like dark blood suppression. And then we have this third type of image that I'll talk about in a little bit that we call it a tissue optimized image. I guess maybe one detail about the methods is that we to kind of account for cases where patients may not have any abnormal enhancement, we chose not to draw an ROI in the scar. And we approximated the T1 and T2 of scar as having the same T1 as blood and the same T2 as viable myocardium. And I'll show you some results later that kind of justify that assumption. Yeah, so to generate the bright blood PSIR image, we use just a standard inversion recovery equation. For the dark blood T2 prepared PSIR images, we basically, we're leveraging the longer T2 of blood to get this dark blood contrast. We introduced this kind of extra parameter called delta. This is an idea that we borrowed from Dr. Peter Kellman, and they have some interesting work with doing multi-parametric SASHA and also doing joint bright and dark blood mapping. But this delta parameter lets us adjust, or lets the user adjust the amount of blood suppression. So basically, if you have a delta that is negative, if you look at this equation, this means that the signal in the blood will be lower than that in the viable myocardium. So maybe if I show you an example going back to these images, I believe this image on the left is a negative delta and the one on the far right is a positive delta. So maybe moving on to this next figure. So this is just showing how we actually simulate both the PSIR and the T2 prepared PSIR images. For the synthetic PSIRs, we can choose any inversion time that we want, and we automatically select the best TI that nulls viable myocardium. For the T2 PSIR images, we're using a sequence that looks like this. So we have a T2 prep, an inversion pulse, and then our simulated acquisition. So we have, for these images, two parameters that we can adjust. That's the inversion time and the T2 prep time. And the paper kind of describes how we do this, but basically the user sets a value for delta, and then we kind of use this equation to try to maximize the contrast between blood, scar, and viable myocardium that's also consistent with the delta value. And then finally, the third type of image that we looked at is something called a tissue optimized image. Kind of the basic idea of this is that we want to generate an image that gives us the best possible contrast between viable myocardium, scar, and blood. So we have these three tissue types. And based on the T1 and T2 values that we measure on the fingerprinting maps, this idea is kind of inspired by fingerprinting. If you look at this diagram, what we do is we optimize a series of an arbitrary series of flip angles and timings, or TRs, in order to kind of maximize the contrast at the end of this acquisition between these three tissue types. So it's kind of a more flexible design. But for example, in this image, you can see that we can get dark myocardium, gray blood, and then bright scar. Yeah, so maybe moving on to our results, just to keep this brief. I'll pull up the supporting material where we show kind of our post-contrast T1 and T2 measurements. So the first analysis we did was just using the maps, looking at the T1 and T2 values in these different tissues. And as we would expect, we see that SCAR has a lower post-contrast T1 than viable myocardium, and both blood and SCAR have very similar post-contrast T1s. For the T2 values, you can see that both viable myocardium and SCAR have kind of overlapping post-contrast T2, and then blood has a significantly higher T2. But this figure also kind of, we're trying to justify our assumption that SCAR has, we can assume that SCAR has a similar T1 as blood and a similar T2 as viable myocardium. Yeah, so then the next figure shows some examples in a few different patients with either prior MI or ischemic cardiomyopathy. So patient number one is a really nice example of a case with subendocardial scar, which you can see right over here. It really shows up nicely on these, both the dark blood images and the tissue optimized image. Patients 2 and 3 are examples where there's this focal scar in this kind of inferior or lateral segment that shows up on all of the contrasts. On patient 3, this is a case where there is a bit of subendocardial enhancement that we can see on the dark blood and tissue optimized images that isn't very clear on the reference image, which is shown on the references on the far right. And then patient 4 is an example with negative LGE on all of the contrasts. And then moving ahead to our other results, we also looked at the contrast between different tissues in the synthetic images. So basically just looking at the mean absolute difference in the signal intensities. So zooming into this graph, you can see that on the bright blood PSIR images, which are in blue, these have very high contrast between normal myocardium and SCAR, but the trade-off is it's hard to distinguish blood versus SCAR. In contrast, in red, with the dark blood images, you can see that kind of has the opposite problem where we have lower contrast. That's the trade-off between viable myocardium and SCAR. And kind of the takeaway with this figure is if you look at the optimized contrast images in green, that achieves the best balance between kind of the advantages of PSIR and the T2 prepared PSIR. So we showed these images to 2 cardiologists who just rated the overall image quality that's shown in panel A. Kind of the takeaway is that in general, all of the synthetic contrasts did got similar ratings compared to the reference LGE, which is shown in blue, with the exception of one of the dark blood T2 PSIR images. Then panels B through D is showing an analysis where we looked at SCAR detection rates. So we used the clinical LGE to determine whether or not a segment truly had enhancement. And then we looked both on a per patient and a per segment basis, where the cardiologist read each of the synthetic contrasts individually. So they read the PSIR images alone and then read the dark blood images alone and so on. And I'd say the most important plot here is the accuracy plot. So if you look here, you can see that in general, the PSIR, this T2 PSIR with the positive delta, which is the gray blood images, and then also the tissue optimized images. These all did had fairly high accuracy compared to the reference. The one exception is this one particular T2 PSIR contrast. Yeah, and then moving ahead to just a few discussion points. So in summary, this is kind of a feasibility study where we show that we can use fingerprinting to get both the quantitative maps and multiple synthetic contrasts in a single breath hold. The tissue optimized contrast, this is kind of a novel contrast that gives us a more equal kind of balance of contrast between these different tissue types. There can be some discrepancies in the way that a synthetic image appears compared to an acquired image, and this can be due to many factors like partial volume effects or kind of simplifications in the fingerprinting dictionary, which affects the maps and then gets translated to the images. And we have some ongoing studies now testing this approach in non-ischemic cardiomyopathy, where the enhancement is more diffuse. Yeah, so I think that covers the most important parts of this work. So I'm happy to hear any questions.
All right, Jesse, thank you so much for that comprehensive, but still short description of the work you've done. So if anyone has any questions, you can go ahead and drop them into the chat, or feel free to raise your hand or unmute yourself. The floor is open.
Yeah, so yeah, thank you. This is really fantastic. Um, what I like about you didn't specifically mention that, but like what I like about this is, and the question is to you is, does it allow us to get rid of the big problem of mapping that you have a difference between the spatial orientation between slices? So you have to basically cobble together slices that may or may not be in the same location. Whereas with this method, you have basically a perfect localization of each slice to get rid of the blurring and other artifacts that are associated with the fact that for T1 mapping, each image may be in a slightly different location because of breathing motion in between.
Yeah, so I would say this study doesn't, to be honest, doesn't answer that question, because it is, it's a 2D scan, but it's I think it's a step towards that direction. So I think like this idea of doing like mapping combined with multi-contrast imaging is really powerful once you start to move to like a 3D or like isotropic scan, where you could do one do one scan and then reformat that in different orientations. And I think that might be some of the work that we're going to hear in the maybe in the next presentation.
Mhm. And maybe just a quick question after. At what point do you think we can get rid of mapping and just move to images that represent pathology? The underlying information may be related to mapping, but most likely a combination of various weightings, map results, etc., so that we go away from black and white to a kind of a quasi-real pathologic representation of tissue pathology.
Yeah, I mean, I think that's the big question. So like we always measure these kind of MR specific, kind of funny properties like T1 and T2, which is not, as we know, is not a one-to-one with pathology.
Uh,
Um,
yeah,
yeah,
because I see a potential there. So thank you. Great, very interesting.
thanks.
All right. Any other questions or comments before we move on? Okay, if not, thank you again, Jesse, and we'll move to our second presenter, Dr. Dong UAC, who is going to be presenting also on synthetic imaging using quantitative maps, but this time, as Jesse alluded to, looking at 3D acquisitions. So I'm going to have Dong Yue go ahead and share your screen, and you can take it away.
Yeah, thank you so much for the introduction. And I'm very glad to have the opportunity to present our latest work. So yeah, I'm going to show this screen. Okay. So I think we probably have the similar background of this of this cardiac MRI for multi-contrast and multiparametric imaging. So as we JC mentioned earlier, now we have the synthetic LTE that can be calculated from T1 and T2 mappings. But previous method is basically like using the 2D sequences, 2D acquisitions, and so it will be time consuming for whole heart coverage. And also previous techniques is basically based on the 1.5 and 3 or 3T scanners. And more recently, we have the 0.55 low field scanners. And I also previously proposed a 3D free bracing joint T1, T2 mapping sequence, which is pretty efficient and can allow the joint acquisition of T1 and T2 of the whole heart at 0.55 T. We have the 2 millimeter isotropic resolution, and the total scan time is within 7 minutes. So in this study, we aim to investigate if the 3D joint T1, T2 mapping at a low field can be used to calculate synthetic LG imaging, and we validate this using a Porcine myocardial infarction model. And so basically, this sequence has been presented in a previous technical paper at MRN. So basically, 3D volumes is acquired using an interleaved scheme using inversion recovery for the first images and non-preparation for the second and T2 preparation for the third. We use the image navigator to allow 100% respiratory scan efficiency. And also the acquisition is 3D Dixon, allows the water and fat separation. So with the 3 images, we use the dictionary matching method to calculate T1 and T2 maps, and as well as a proton density map. So with these 3 contrasts, we proposed an IR signal model and a T2 IR signal model to calculate the different contrast weighted LGE images. Specifically for the IR signal model, we used like this signal model. In this one, we included both the proton density and the T1 to calculate this contrast. So for IR LGE, we have different contrast to know either myocardium or blood pool using the TI time calculated to allow to make this myocardium or blood signal to be 0. Also, for the T2 IR signal model, this signal is calculated with proton density, T1 and T2 values. And so with T2 IR signal model, we are able to calculate this dark blood LGE to know blood pool and myocardium simultaneously. So these are the 3 different synthetic LGE images we aim to generate. So this study was performed actually at the Ohio State University. Totally, we have the data of 10 myocardium swan, myocardial infarctions one, and at either 1 week post-myocardial infarction or 5 week post-myocardial infarction. Here are the representative results of T1 and T2. Firstly, we compared the synthetic LGE with and without the proton density. So with the proton density in this signal model, we can suppress the signal of the background so that can get rid of this noise in the background and make this image cleaner and as comparable with directly acquired 2D sequences. So, and also for the IRLG with different TI time, we can achieve multiple different contrast, as well as for the T2 IRLG. For example, with this TI, we can able to suppress blood and myocardium at the same time. So this is also a representative result from a swan acquired at 5 week post-myocardial infarction. We have the post-contrast T1 maps and the T2 maps. So the synthetic bright blood IRLG have a comparable image contrast with the 2D LGE. We can see this myocardium scar at this area, while the gray blood IRLGE, we have a better contrast between scar and myocardium. Regarding the dark blood T2 IRLGE, actually we don't have a good contrast for the structure of the heart, but this can be used to highlight the scar area. So we also did some, so this is the Porcine plot using the 3D data. This can allow us to evaluate the myocardium scar across the entire heart. And this is also a representative result from 2 different one at 1 week. So for the first one, we can see the myocardial infarction with intramyocardial hemorrhage in this case. And this is also can be picked with both T1 and T2. Probably better contrast in T1. T2 is not that obvious. And also the synthetic IR-LGE, this is comparable with this 2D LGE images, and the area of the hemorrhage is a bit different. So that is probably due to the different imaging time after contrast. And also for this gray blood and dark blood LGE, we can see this area. For the other one is like no hemorrhage, and similarly, we have a consistent result between the synthetic LGE and the directly acquired 2D LGE. So we also did some quantitative analysis of the T1 and T2 values of different tissues. Actually, the 3D joint T1 and T2 mapping have consistent results with the 2D T1 and T2 maps. Both can show significantly reduced T1 in the scar compared to remote myocardium, and increase the T2 in the scar compared to the remote myocardium. For the image contrast, so the 3D bright blood synthetic IR-LGE is actually comparable with the 2D LGE, which is also a bright blood contrast. But the gray blood LGE, we have a better scar to blood contrast and also a better scar to myocardium contrast. And the blood to myocardium contrast is comparable. While for the dark blood LGE, the scarred blood contrast and the scarred myocardium contrast are both increased compared to the bright blood LGE, and the blood to myocardium contrast is significantly lower than the bright blood LGE because both the blood and the myocardium are suppressed. So basically, this is all the results presented. So actually, JC just mentioned that they have an optimized image contrast using their different synthetic equations to calculate the signal. And actually, I think this should 3D acquisition should also be compatible to that technique. And also, there are some limitations in this study. Firstly, is actually the T2 mapping is acquired post-contrast, which is actually not very usually in clinical settings. And yeah, and also the in-plan resolution of the 3D acquisition is actually slightly lower than the 2D, but the 3D have the advantage of whole heart coverage, and we can reformate the 3D to different 2D orientations. Yeah, so that's basically that. Thank you very much.
Excellent. Again, thank you for a really nice description of this great work. Are there any questions? Feel free to drop them in the chat again, or you can. Oh, Jesse, perfect. Raise your hand. Good
I had a
example.
quick question. This is amazing work, and the fact that this is at 0.55 T, like these are great images. I was just curious if you had any thoughts for what is the best way to present these images to a clinician, because this is like really high dimensional data. We have maps and then like all these different contrasts. Is it effective to show like all of the possible inversion times to a clinician, or just like a subset? It's something we've kind of struggled with.
Yeah, thank you so much for the questions. So actually, I think that is even more challenging with the 3D whole heart data. So I think one way we are trying to present this data is using this high resolution bullseye plot. I think that is like making this 3D data into a 2D view that can be used to show the scar area of the whole heart. So that's what I think may be potential to view that. And actually, regarding the different contrast, I think actually one question raised during the review of this paper is that the clinicians may not be really like the dark blood contrast because we lose the contrast of the structure of the heart. So probably the gray blood contrast is somehow preferred by the clinicians because we can see all the structures within only one contrast. So I think that maybe also requires further validation of the clinicians to show which one is the best.
Thanks.
All right, we have one question in the chat, which is whether you've looked at your effective image resolution versus the acquired resolution in the 3D scan. So I think the question here is about the nominal resolution and versus the actual acquired resolution.
Okay, so the acquisition resolution of the 3D sequence is 2 mm isotropic. But I think somehow it may be smoother because this is low field scan and we apply the HD plus denoising in these images. Anyway, that is still lower than the 2D sequence because that acquisition of the 2D is 1.7 millimeter in plane resolution. So yeah, that is potentially one limitation of the 3D sequence. But I think probably with the future investigation of the super resolution, maybe can help improve some of the 3D resolutions.
Maybe just to follow up on that. So, I mean, this is a comment that I think I hear sometimes about the mapping versus acquired LGE, that the acquired LGE has a higher resolution, so it's just kind of easier to see things. Is there any fundamental limitation of your acquisition, or would it just be increasing the scan time in order to increase your resolution?
Yeah, I think that will be more challenging at the low field, especially regarding the low SNR. So and also the TR will be longer at 0.55 T due to the limited gradient performance. So basically, if we keep pushing the resolution, we will have a very long scan time and maybe further influence the SNR. So currently we just use a 2 millimeter resolution, but I think potentially we can make this to 1.5 or even more. Yeah.
Okay, perfect. Oh, go ahead, Ed.
Yeah, really super work. But just to follow up on the resolution issue, do you think it could be, as I understand it, you're acquiring a coronal stack and then reorienting to short axis, and maybe some of those steps have an effect on resolution as well?
Actually, yeah, I don't think the reformatting will decrease the resolution because it is 2 millimeter isotropic. So that should be equivalent to the real acquisition resolution. So it should be still 2 millimeter. That's my understanding.
Okay, perfect. Any other questions or comments? Okay, if not, then we will adjourn. I know that Matthias has a plan for our June meeting. Oh, perfect. Here we go. Oh, Matthias, you're muted.
Okay, thank you, Nicole. Yeah, first of all, thank you, fantastic, very interesting everything. So we stay on a little bit on that topic for next month, going needle free, and we will have a look at 2 interesting papers. One is on a non-invasive model of measuring venous oxygen saturation in heart failure. was very interesting work going back to work from Pankaj Garg, and now it's with the leads team with Peter Svoboda presenting this. And then a bit related to that, measuring myocardial blood flow and flow reserve with AI-supported technology, and so with MR during exercise. That's work from Reza Nezafat's team. So very interesting, and I hope I can see all of you there then on June 3rd. Thank you.
Awesome. Thanks so much, Matthias. Thank you to our presenters again. Thank you for your patience with my slight delay. And I hope to see many of you in Cape Town, and then, of course, next month. So have a great rest of your day.
Thank you.
Thank you. Bye.